Okay, and our last speaker today is Dr. Heather Navlin. She's from, I got to get this right, Manning Family Hospital now and LSU. She is, I'm sure, going to do an even better job than our Dr. Zach LeBlanc, who is supposed to give this talk. And she's going to be talking about ways of measuring MRD in ALL, which is a really important thing.
Yep. So good afternoon. My name is Heather Valdin. I'm the third year pediatric hematology oncology fellow with LSU and at Manning Family Children's, and I'll be talking about assessing treatment response in pediatric BALL in modern times, or when leukemia is bad. So we're going to focus on relapse and refractory BALL, and our objectives today are to define the prognostic features for pediatric BALL, to outline treatment options tailored to results of modern testing, and then to describe an approach to relapse and refractory BALL. So we'll focus on about 3 cases that we've seen recently, including a 12-year-old girl with marrow and bony relapse, 30 months off therapy, a 22-year-old man with poor 6-MP adherence, relapse during maintenance, and then a 7-year-old girl with induction failure. So just as an overview, pediatric BALL is really the greatest success story of pediatric oncology. And as you can see to this graph on the right, the overall survival for these kids is now reaching greater than 95%. And that's due largely to clinical trial research that has established this current standard of care, including a 3 or 4 drug induction based on their NCI staging, consolidation, interim maintenances, DI, and maintenance. And now with our newest addition being CD19 targeted immunotherapy, due to the amazing results of AALL 1731. And you can see that our 5-year overall survivals are pretty incredible, and now even potentially better with the incorporation of blinatumomab for everyone up front. So we're going to discuss, unfortunately, that small percentage of patients who don't necessarily fit into that category. And so I want to focus on the prognostic features of ALL first. So this is just a general list that one can refer to when assessing a patient's overall prognosis, and this includes their NCI staging, which is based on your age or your initial white blood cell count at diagnosis, and your cytogenetics. But ultimately, I want to highlight that MRD, or minimal residual disease, to the 0.01% at the end of induction remains the most predictive of a patient's prognosis, and that will trump everything. It's also important to note that sanctuary site involvement and steroid pretreatment will also surpass NCI staging, and that will increase a patient's risk stratification. So to talk about BALL prognostic cytogenetics, we're going to talk about our favorable and unfavorable ones. So our favorable ones that we love to see are our ETV6 RUNX1 and our double trisomies 4 and 10. And then the ones we don't like to see are the Philadelphia chromosome or 922, our KMT2A or MLL with any partner, and then haplodiploidy, among others. So relapse risk stratification is a little different and depends on a few things. And so for BALL, it really comes down to time of relapse from your initial diagnosis and then your MRD at the end of reinduction. So our high-risk relapse kids are those with either T-cell at any time, or they have early relapse less than 36 months from your bone marrow. So less than 36 months from your initial diagnosis, or less than 18 months if extramedullary disease. Our low are our late relapsers who are greater than 36 months marrow and then greater than 18 months extramedullary, and they have to be MRD negative at the end of reinduction. And then our intermediate kids are those late relapse kids who are MRD positive at the end of induction, and we'll get into why this matters. So our first case, your cute, now 12-year-old with BALL relapsed 30 months after the completion of therapy. So she has late relapse, and so what's next? So this is a landmark trial, ALL-R3, that initially investigated treatment for those in late relapse. And R3 was an open-label randomized control trial that investigated those with BALL and late relapse, and just to point out, this is prior to targeted therapy with CAR-T and blinatumomab. And so these patients received reinduction either with idarubicin or mitoxantrone, and then based on their MRD, you were stratified to either continue chemo or to proceed with BMT. And focusing on the induction part, that randomization was stopped early, and all patients were allocated to receive mitoxantrone due to substantial effect on their progression-free survival despite similar MRD levels at the end of induction for both groups. Additionally, comparing the overall survival between of those based on MRD following induction. So they utilized MRD as less than 0.01% to determine the need for bone marrow transplant. So MRD negative individuals were deemed low risk. They had favorable outcomes with chemotherapy alone without transplant, with a progressive free survival of 72%, meaning for late relapse patients who are MRD negative at the end of induction, utilizing 3 drugs plus mitoxantrone, there's no benefit of BMT compared to chemotherapy alone. Those with MRD positivity following induction went to transplant, and they had a progression-free survival of 56%. So really, this study pointed out 3 things. It shows us that MRD matters, especially in the setting of relapse, that patients with negative MRDs can essentially skip transplant, and that these regimens are extremely toxic, particularly in already heavily pretreated patients, and outcomes are really not favorable. So this highlighted the need for possible targeted therapy. And that brings us to AALL 1331, which was the first COG trial incorporating blinatumomab into therapy for those in relapse. So, but first, how does Blina work? I'm not going to do the video because I don't know how to work technology very well. But essentially, Blina was first used in the COG trial 1331. It's a BiTE or a bispecific T cell engager, meaning one side binds to the CD3 T cells, the other side binds to CD19 leukemia cells or just any B cells, and it brings them together forcibly to induce T cell mediated death to those cancer cells. And so it's a 28-day continuous infusion. It has actually a really short half-life, and it only is in your system when it's infusing. So back to those low-risk kids. And so AALL 1331 for low-risk patients, they found that there was no difference between chemo and Blina for disease-free or overall survival in low-risk patients, but those who got Blina had fewer hematologic and infectious complications. Additionally, this study noted that the addition of Blina significantly improved the overall survival compared to that R3 regimen, signifying that this is like the new standard of care for late relapse low-risk patients. So back to our case, she was a late medullary and extramedullary relapse, and she was clonoSEQ, which we'll talk about in a second, and NGS without a targetable lesion. She underwent reinduction per AALL 1331 with mitoxantrone, and at the end, she was MRD negative, clonoSEQ negative, and PET-CT negative, and then she completed therapy via this protocol with blinatumomab. So a little bit about clonoSEQ. So the utilization of what we call deep MRD with a sensitivity of 10 to the -6 in relapse ALL has been explored in several studies. clonoSEQ is a method that amplifies antigen receptor gene segments and identifies clonal gene rearrangements. Essentially, it's able to identify an MRD positive sample that were negative by conventional methods like flow. And so in the case of utilizing clonoSEQ or deep MRD post-transplant, you can see here via this orange line that those who are both MRD negative and clonoSEQ negative, so 10 to the -6, have less risk of relapse, meaning clonoSEQ post-transplant is predictive of relapse. So on to our next case, we have our 22-year-old man who has blasts on his CBC during maintenance therapy, confirmed CD19 positive relapse, and he's previously known to have poor adherence to his oral chemotherapy. So we know there's an indication for transplant because he's an early relapse kid, but how do we get there? So back to AALL 1331, we need to build a bridge to transplant, essentially using blinatumomab. So 1331 compared Blina as a bridge to consolidative chemotherapy as a bridge in these high-risk patients. And what they found was that those in the Blina arm were more likely to enter transplant in an MRD negative remission and had an improved disease-free and overall survival compared to the consolidative chemo group. It also, again, spared these patients of significant side effects, toxicity, and delays in treatment prior to transplant. So 2 cycles of Blina, you're more likely to become MRD negative, and then you can proceed to transplant without delays. And just to show, this has been repeated through other international studies as well. And that Blina arm was pretty similar in both studies at around the overall survival, about 80%. So going back to case 2, he was a high-risk relapse due to his time from relapse. He had reinduction with AALL 1331 with 3 drugs of mitoxantrone, and he was in a medullary remission, but he remains clonoSEQ and MRD positive. NGS was performed without a targetable lesion, and he received 2 cycles of Blina, where he eventually became negative for both clonoSEQ and MRD and proceeded to transplant. So this is our last case, an induction failure. So we have a 7-year-old with 85% blasts on her day 29 end of induction bone marrow. This brings us to discussing NGS testing, as I've kind of alluded to earlier in this talk. So NGS, or next-gen sequencing via Foundation 1 heme testing, can be performed on the marrows of kids with BALL. And it issues a report of identified lesions and if there are targeted medicines that can be added to the chemotherapy backbone. It's particularly useful in identifying this growing subset of Philadelphia chromosome-like ALLs, which are found to have significantly inferior outcomes compared to ALLs that don't have Philadelphia-like phenotype. And some of these can be targeted with either TKIs or JAK inhibitors off-label. And so this was actually a recently published paper, or a How I Treat article. And so as a fellow, I love those, and they're my favorite thing to read. But it was actually published in January of 2025. And they stated that studies have demonstrated that 15 to 25%, so a really large proportion of NCI high-risk patients, and about 5 to 10% of standard risk have Philadelphia-like ALL that can potentially be targeted. And this percentage increases with age. So this paper created an algorithm to follow, which is similar to what we do at our with our case that we'll talk about and at our institution. And they recommend the addition of a TKI for ABL class alterations as soon as you detect it. And then for those who are a CRLF2 or a JAK pathway alteration, you can consider ruxolitinib or Jakafi, particularly for those who are not achieved remission in induction that have like an M2 or an M3 marrow at the end of induction. So in the case of our patients like this with refractory BALL and induction failure, we want to discuss CAR T therapy and its indications. So Tisagen Lifileucel, or now known as Kymriah, is indicated for patients with BALL that's either refractory or in their second or later relapse. And this landmark trial, the Eliana trial, led to the FDA approval in children. So the Eliana trial was the initial CAR T trial utilizing CD19-directed T cells, enrolling patients, like I said, with either refractory or second or more relapse of BALL. So like the talk alluded to earlier, these kids were really at the end of the line without any options. And it demonstrated a high overall remission rate of about 80% within the 6 months of infusion. And to highlight, all of those responses were MRD and clonoSEQ negative, so really amazing. And the results also suggested that Kymriah could provide a durable remission, like we talked about earlier in the session. So since then, there's been some secondary analyses, however, that have evaluated the longevity of these cells. And what we did find is that for some kids, the duration of that remission decreases steadily over time in the long-term follow-up. So this is really a hot topic about who needs to be brought to transplant. Is CAR T definitive therapy? And so this is a joke that Dr. LeBlanc included, but satisfied I am not by Yoda, probably after reading the Eliana long-term data. So when looking at secondary analyses of the long-term outcomes post-Eliana, we've highlighted 2 big predictors of relapse for those post-CAR T, and that includes people who lose B-cell aplasia, particularly under 6 months, and those who are clonoSEQ positive after CAR T infusion. And so here on the right demonstrates each line is the time from loss of B-cell aplasia at 3, 6, 9, and 12 months. And you can see that the event-free survival correlates with this. So it's, there's no way to predict when or if they're going to lose B-cell aplasia. And so it kind of highlights that some of these kids could be a ticking time bomb. And like we highlighted earlier, a lot of these relapses are CD19 negative, which severely limits your options. So here again, referring to clonoSEQ, this we're demonstrating that those who go into transplant clonoSEQ positive are significantly more likely to relapse post-transplant than those who are negative. So it's hard to say who we should use CAR T as definitive therapy for. And I think a lot of centers are working towards utilizing this as a bridge to transplant, knowing that if we wait until they lose B-cell aplasia, or if we wait until they're clonoSEQ positive, we may have waited too long. So just digging in a little bit into bone marrow transplant, this is a Sentinel paper that was published in 2003 and established that total body irradiation, or TBI, is superior to busulfan myeloablative conditioning regimen. So they randomized people to either receive TBI and cyclophosphamide and VP16, or busulfan and cyclophosphamide and VP16, and the overall survival for those who received TBI and Cy was 67% compared to 43% in the busulfan group. And this is specific to ALL because BuCy is still the preferred regimen for AMLs. And so this is the regimen that we use. And so this paper kind of compares the relapse outcomes for patients with pediatric B-ALL post-transplant. And they noted some really interesting findings. It found that patients who actually have very mild grade 1 or 2 GVHD, it's associated with a lower risk of relapse. And this is attributed to graft versus leukemia effect, which is really cool. So particularly, we want patients with grade 1, 2 acute GVHD without the development of chronic GVHD. They have the best overall outcomes in relation to relapse protection from GVL and transplant-related morbidity. And so they did find that grade 3 and 4 GVHD did have a protective effect for relapse, but given that they have such high rates of transplant-related morbidity and mortality, that negates this and results in inferior outcomes. So back to case 3, her end of induction marrow had 85% blasts, indicative of induction failure. She went through consolidative chemotherapy with still not in a remission of 10% blasts. And so she was transferred to our center for a CAR T consult. We did perform NGS, and she actually had a targetable lesion of IGH-EPOR rearrangement, which is a JAK pathway alteration. And so she was started on ruxolitinib and bridged with interim maintenance 1 high-dose methotrexate. She ended up receiving CAR T with an MRD of 7% going into CAR T transplant, and then following CAR T, she was MRD and clonoSEQ negative, so she was brought to transplant. And so far her day 30 MRD is negative, and she was actually discharged on Monday, so clonoSEQ is pending, so we'll know. But and I'm not quite sure what Dr. LeBlanc meant by this matrix. I'm assuming just slowing down time, taking a minute, you have all of this information and bullets coming at you. And so, I think it's just highlighting the importance that like every patient is very different. And so we want to make sure that we're considering all aspects of their prognostic features for treatment. And so just as an overview of relapse ALL or refractory ALL, so poor prognostic features need to drive decision-making about when to deviate from upfront standard of care therapy, and they're not just for us to memorize for the boards. Risk stratification for relapse ALL is largely determined by the timing of relapse and the response to reinduction. Targeted therapies detected via NGS are valuable in the pre- and post-transplant settings, and then detection of deep MRD by clonoSEQ testing aids in determination of therapy needed. And then our low-risk transplant kids can be managed with 3 drugs plus mitoxantrone, so a 4-drug reinduction, blinatumomab, and 2 years of chemo. And then our high-risk kids, it's really an evolving space, and there's many options and unresolved questions, but BMT will remain the goal for lasting cure. And lastly, TBI remains the preferred regimen for ALL. And that's it. So.